Assalamu alaikum wa rahmatullah. Today we will talk about some of the major physiological changes that take place after shortly after birth, or the some of the characteristics of the physiology of the fetus before birth. So the development of the organ systems of the fetus starts within the first month. The development is going to be very gross, and there will be a growth of certain characteristics of different organs in the fetus, and they will start to develop, of course, very poorly. Within the first month, the major concentration is on the development of the placenta. Then during the next 2 to 3 months, most of the details of the different organs are going to be established, and just beyond the 4th month, the organs of the fetus are going to be grossly the same as those in the neonate or the newborn. However, at the cellular level, development of each organ is still incomplete and needs to be completed in the remaining 5 months of pregnancy. They are very important in completion of the development, and still after birth, some of the systems and organs, they need further development, such as the nervous system, the kidney, and so many organs. They need to further develop after birth within the early months of the neonatal life. The development of the organ systems, we will start with the circulatory system. The human heart actually begins beating during the 4th week of gestation, and the beat rate, or the rate, is about 65 beats per minute, and this rate is going to be increased to reach 140 beats per minute immediately before birth. Fetal circulation is so much different from the neonatal and adult circulation. It's characterized by having very low blood flow to lungs and liver that are partially functional, and we know that the lungs are they have no air in order to be functional, and the liver also is partially functional. So these organs have low blood flow. In contrary, there is high blood flow to the placenta. As you can see here in the figure, the oxygenated blood is coming from the placenta to the fetus through umbilical vein. And the umbilical vein, as you can see here, will be connected to the ductus venosus. And the ductus venosus will bypass the liver to transport blood into the inferior vena cava. So it makes a shunt for the oxygenated blood from the umbilical vein into the inferior vena cava. So this oxygenated blood will continue its path into the heart, into of course, the right atrium of the heart, through the inferior vena cava into the right heart, the right atrium of the heart. Now it will have another shunt from the right to the left atrium of the heart through a foramen that is only present here in fetal life. It's called foramen ovale. So the foramen ovale will shunt oxygenated blood from the right side to the left atrium of the heart. So now the oxygenated blood will be in the left side instead of the right side. And of course, after that, after being pumped, it will be pumped to the left ventricle. So oxygenated blood will pass through the aorta and then into the upper parts of the body, the head and neck, and the upper or fore limbs. So this is the path of the oxygenated blood. If we look at the deoxygenated blood, that enters from the pulmonary or superior vena cava, okay, coming from the pulmonary circulation through the superior vena cava and from the head and neck, of course. So this deoxygenated blood will enter the right atrium and then will move down into the right ventricle. So it has another path, different than the path of the blood coming from the inferior vena cava that is shunted to the left atrium. The blood that is coming from superior vena cava has a different path. It will go directly through the tricuspid valve into the right ventricle, and then it will be pumped through the pulmonary arteries, okay? And through the pulmonary arteries, it will be shunted again through a vessel that is only characteristic of the fetal circulation called ductal arteriosus. So blood that is going from the right ventricle will be pumped through the pulmonary artery, through the ductus arteriosus, and shunted into the descending aorta. So from the descending aorta, it will go into the two umbilical cords. As you can see, descending aorta will continue downward into the two umbilical cords. So deoxygenated blood will continue going to the placenta where oxygenation will take place, and the circle will go over and over. Now, one of the organ systems that has certain or special characteristics during the fetal life is the blood cells forming system. There are nucleated red blood cells that begin to form in the yolk sac and also from the mesothelial layers of the placenta beginning in the third week of fetal development. So that's the beginning of formation of red blood cells. They start forming as nucleated red blood cells. And then at 4 to 5 weeks of gestation, non-nucleated red blood cells, which are similar to our red blood cells, which are non-nucleated, will be formed from the fetal mesenchyme. At the 6th week, the liver will start to form blood cells, red blood cells that are identical to our red blood cells. However, in the 3rd month, the spleen and other lymphoid tissues will start forming red blood cells. And after the 3rd month, the bone marrow will start forming red blood cells and going to dominate. It will be the principal source of red blood cells as well as white blood cells. Regarding the respiratory system, of course, respiration, it's not gonna take place during the fetal life, but there are attempts for respiratory movements that take place beginning at the end of the 1st trimester of pregnancy. And these attempted respiratory movements are caused either by tactile stimuli or by the fetal asphyxia. In the later months of fetal life, in the 3rd trimester, respiration, for unknown reason, is going to be inhibited. Even these filling or movements are going to be inhibited. So filling of the lungs will be also prevented so that all fluids and debris or meconium that can be present or filled, the lungs filled with these substances are going to be emptied, and the lungs will be deflated until the birth. So they are going to be clear of these fluids. However, the alveoli will secrete clear fluid instead at the later months that is secreted by the alveoli and not taken up from the amniotic fluid. Regarding the nervous system during the fetal life, reflexes of the fetus that involves the spinal cord as well as the brainstem. It's present, or they are present, by the 3rd to 4th months of pregnancy. The nervous system functions, which involve cerebral cortex, are very poorly developed in the early stages of development, even after birth. For example, myelination of the main tracts will not be completed before the 1st year of age. So even after birth, it still needs further development, the cerebral cortex development. Regarding the gastrointestinal tract, during the fetal life, small quantities of meconium, which is composed of swallowed amniotic fluid, excreted from the anus into the amniotic fluid. So these quantities of meconium are formed continuously in the last 2 to 3 months, and this meconium is composed of amniotic fluids that has been swallowed, mucus, epithelial cells, excretory products from the mucosa, and the glands of the gastrointestinal system. Regarding the renal system in the fetal life, fetal kidneys start to excrete urine and become functional in the 2nd trimester of pregnancy. And actually, the fetal urine accounts for the majority of the amniotic fluid composition. The fetal kidneys, they actually develop Regarding fetal metabolism, the fetus uses mainly glucose for energy, and also it has a high capability to store fat and protein. The fat in the fetus is produced from glucose rather than being transported or absorbed directly from the mother's blood. Regarding metabolism of calcium and phosphate, they are both required by the fetus and accumulate in an average of 22 grams of calcium and 13 grams of phosphorus during the period of gestation. 1/2 of these amounts that are required accumulate during the last 4 weeks of gestation. However, the total amount of calcium and phosphate required and accumulated by the fetus only represent 2% of the mom stores. So the fetus does not use up the stores, or do not use a large percentage of the calcium stores of the mom, not or unlike to after birth, where nursing moms will lose large percentage of their calcium stores in the bone. Regarding iron, about 1/3 of iron in a fully developed fetus is stored in the liver in order to be used, especially after birth, for the synthesis of the hemoglobin and new RBCs, or red blood cells. Several vitamins are important to be utilized and stored in the fetal life. For example, vitamin B, and especially vitamin B12 and folic acids, are necessary for the formation of red blood cells as well as the nervous tissue. Vitamin C is also important for the formation of intercellular substances, bone and connective tissue fibers. Vitamin D is also important for normal growth of the fetus bones, and also after birth to be used for the absorption of calcium from the digestive system. Vitamin K is also stored by the fetal liver, and it's important for the formation of factor 7 and prothrombin and other clotting factors. It is important because the fetus will not be able to produce vitamin K in the first week or so, and coagulation is important, especially after the baby is subjected to trauma during labor, and it helps prevent the hemorrhage during labor. So having intact coagulation system and vitamin K stored in the baby is important at this stage. Now let's talk about the extrauterine life. There are many important adjustments of the infant to extrauterine life. One of those important adjustments is the onset of breathing. The baby, after it's being born, it will start breathing within the first minutes, and that is a result of the slightly asphyxiated status during birth process, and also can be also stimulated due to the sensory impulses that originate due to the sudden cooling of the skin after delivery of the baby. And if the baby did not start in the first minute due to the previous reasons, it will get more hypoxic and more hypercapnic. So there will be low oxygen pressure and high carbon dioxide. That will stimulate the respiratory center and will initiate breathing with an additional minute after birth. So in summary, within the first 1 to 2 minutes, the baby will start breathing after labor, and that if the mother did not have did not get too much of anesthesia, because it will suppress the baby's respiratory center as well. Now, what if the baby did not start breathing in the first 2 minutes? If we look at the adult, failure to breathe for only 4 minutes will often cause death. However, in neonate, it can be as long as 10 minutes or a little bit less of failure of breath after birth, and the baby may not die from that failure. However, permanent and very severe brain impairment often take place if breathing was delayed more than 8 minutes, from 8 to 10 minutes, and mainly thalamus and brain stem will be affected, affecting the motor centers. The reason of hypoxia or reasons of hypoxia that may occur during delivery are either due to the compression of the umbilical cord that will cut off the supply, especially oxygen from the baby during the process of labor. Also, premature separation of the placenta, as well as excessive contraction of the uterus during labor. This also can cut off the blood flow to the placenta and thus the blood flow to the baby. And finally, excessive anesthesia of the mother will depress the oxygenation in the mother and in the fetus as well. And those are the main reasons of hypoxia that may occur during delivery. Now let's talk deeply in the process of respiration, the early breath or the first breath. How does it take place? So once the baby is born, the alveoli are going to be deflated, and in the last weeks of gestation, just before birth, there will be secretions by the alveoli of a substance that is called surfactant. And this substance actually reduces the surface tension of the alveolar fluid, and it will make inflation of the alveoli and filling the alveoli to be easier. So, to inflate the collapsed alveoli once the baby is born, we need more than 25 millimeter mercury of negative inspiratory pressure in the lungs in order to oppose the effect of surface tension of the collapsed alveoli to open the alveoli for the first time. And this is considered a large negative pressure, but it is less than what is needed if the surfactant is not there. So in respiratory distress syndrome, it's caused by failure of the respiratory epithelium to secrete adequate surfactant. So a reduction of the surface surfactant will have the surface tension to be increased, and then it's going to be hard to inflate the alveoli and perform the inspiration for the first time or on the long run. In these graphs, pressure volume curves of the or the compliance in the lung to take the first breath, it shows how is it hard to take the first breath. As you can see here on the x-axis, we know that the alveoli before first breath are collapsed, and there is liquid in the alveoli, so there is surface tension. In order to inflate the alveoli, we need to oppose this surface tension to inflate and open up the alveoli. So as you can see here, for the first breath, the alveoli cannot be filled with air until the negative pressure in the interpleural cavity exceeds -40. Then we will start seeing the curve, the volume, the filling here as shown in the curve. Okay, so at about -60 millimeter mercury of negative interpleural pressure, we will see filling of about 40 mils. So that means the first breath requires extreme pressure, extreme negative pressure in order to initiate and inflate the alveoli for the first time. On the other hand, if we look at the deflation of the alveoli, we will see that also we need a large positive pressure in order to deflate the alveoli, and that's because of the resistance of the viscosity or the viscous fluid that is in the bronchioles. So in summary, for the first breath, we need extreme pressure values to inflate and deflate the alveoli. And fortunately, the fetus is able, by the inspiratory movement, to produce a forceful inspirations that are enough to produce even up to the -60 of negative interpleural pressure in order to take the first breath. As you can see here, in the second breath, it gets a little bit easier. So it's going to take about -20 in order to increase the volume and inflate the alveoli, and maximally -40. And then the deflation also will take about less than positive 20 millimeter mercury in order to deflate the alveoli or the lung. And it gets easier with time. After 40 minutes, the respiration will be very similar to the adult respiration in terms of the pressures, the negative and positive pressures required to inflate and deflate the alveoli. Now let's talk about the cardiovascular adjustments that take place in the extrauterine life. And it's also very important, as well as the first breath. So we discussed in the beginning the circulation of the fetus, and there are some shunts and differences between the fetal and the adult circulation, due to the placenta, the high or large blood flow to the placenta, and due to the low blood flow in the lungs and in the liver. After delivery, there are going to be changes to these findings. So one of the primary changes that will take place in the pulmonary and systemic circulation is that first, the loss of placenta, loss of blood flow, the large blood flow through the placenta after delivery and detachment from the placenta of the baby. This will double the systemic vascular resistance at birth. And we know that if we remove an organ from any one of us, this will transiently increase peripheral resistance. And that's what happens when we remove the placenta. There will be loss of blood flow and there will be increase in vascular resistance. It's going to be double the vascular resistance before birth. This will affect the aortic pressure. It will increase as well, and also the left side of the heart, in the left ventricle and in the left atrium, as result to the increased total peripheral resistance, the blood pressure, arterial blood pressure, and the blood pressure in the ventricle and left atrium will be increased as well. The second changes occur because of the lung expansion. Once the first breath is taking, the second breath, there will be changes in the pulmonary expansion. It will be full of air now, and the vascular resistance will decrease greatly. So the vascular resistance in the lungs will decrease because of the expansion of the collapsed lung. So the blood vessels are no more collapsed, so they will be dilated and expanded, and that will decrease the resistance in the lungs vessels. As well, pulmonary arteries and right atrium, as well as the right ventricle, will decrease. So the pressures in the pulmonary artery, the right atrium, and the right ventricle will decrease as a result to the decrease in the pulmonary vascular resistance. So these are the two major changes that take place to the vascular system and cardiovascular system after birth. One of the main events that take place due to the changes that we discussed in systemic peripheral resistance as well as in pulmonary resistance. First, there will be closure of the foramen ovale. And what causes the closure of foramen ovale? The foramen ovale at the beginning in the fetal life facilitates the transport of oxygenated blood from the right into the left atrium. Okay, the oxygenated blood that is coming from the placenta through the inferior vena cava. So when the right atrial pressure falls and the left atrial pressure increases due to the changes of the peripheral resistance, this will cause blood to attempt to flow backward from the left atrium into the right atrium, because the blood or any fluid tend to flow from the high to the low pressures. So this attempt will cause the foramen ovale valve to close. So then the foramen ovale will close due to these changes in pressure values. which actually occurs opposite to fetal life. In fetal life, the pressure is higher in the right, higher than the left. But after taking the first breath and starting expansion of the lung, there will be changes in the pulmonary circulation. The resistance will decrease. In the left side of the heart, the pressure will be increased, as well as the total peripheral resistance due to the loss of placenta flow, and this actually will lead to the closure of the foramen ovale. Now, the second event that takes place is the closure of another vessel that is called the ductus arteriosus, that was established in the fetus. Ductus arteriosus closes due first to the increased systemic resistance that will lead to the increase of resistance in the aorta, and the aortic pressure. There will be increase, while there is a decrease in the pulmonary arterial pressure. As you can see here, the pulmonary arterial pressure is going to be decreased here, and we know that the ductus arteriosus in the fetus links between the pulmonary arteries and the aorta. So this is the ductus arteriosus. So when the pressure in the aorta increases and the pressure in the pulmonary arteries decreases, then in the same manner the blood will tend to flow back from the aorta into the pulmonary artery through the ductus arteriosus, rather than the other direction that take place during the fetal life, which is from the pulmonary into the aorta, descending aorta. So this will lead to contraction or collapse of the ductus arteriosus, which is aided by several factors. One of them is the high oxygen partial pressure after birth. Because of the high oxygenated status, the oxygen pressure will increase from 20 to 100 millimeter mercury. And that will induce, according to experimental results, will induce contraction or spasm in the ductus arteriosus. This is one factor. The other factor is that there will be lower vasodilator prostaglandins, the prostaglandin E2, which has been a reason to vasodilate the ductus arteriosus in fetus. So lower levels of prostaglandin, the vasodilator type, lower level of that after birth will induce the contraction or the spasm of the ductus arteriosus. This was actually demonstrated when failure of closure was prevented by treatment of indomethacin. Indomethacin is a blocker for prostaglandin synthesis. So that actually suggests a role for the prostaglandins in the contraction or in the obliteration, blockade of the ductus arteriosus. One of the major or the main adjustments of the fetal circulation to the extrauterine life is the closure of the ductus venosus. So after birth, immediately the blood flow in the umbilical vein will cease due to the disconnection of the placenta. So the blood flow here will stop, but still there will be portal blood that will flow through the ductus venosus. However, the blood flow through ductus venosus will be reduced due to the loss of umbilical vein blood flow. However, after about 3 hours, the blood flow through the ductus venosus also will be reduced, diminished, due to the contraction, the strong contraction of the ductus venosus. That is not very well known, the mechanism of that contraction will close the flow within the ductus venosus from the portal circulation. And that actually will build a pressure in the portal vessels or circulation that will reach about 10 millimeter mercury and will force the portal venous blood to flow through the sinuses of the liver. So then the blood flow in the liver will be enhanced greatly after the closure or the complete closure of the ductus venosus. In a newborn, the normal respiratory rate in a neonate is about 40 breaths per minute, and the tidal volume is about 16 milliliters. The blood volume in the circulatory system of the neonate is about 300 milliliters, and it is considered very low volume. But if the infant was left attached to the placenta for a few minutes and the blood was stripped and forced to come out of the vessels from the umbilical cord into the baby, then maybe an additional of 75 milliliters can enter the infant circulation, making it up to 375 milliliters. The cardiac output of a neonate is about 500 ml per minute, and it's considered greater than the cardiac output in an adult, of course taking weight into consideration. And the arterial pressure during the first day of the neonate averages about 70 millimeter mercury systolic and 50 millimeter mercury diastolic, and this increases slowly during the early months to about 90 systolic and 60 diastolic millimeter mercury. The red blood cells of the neonate, the count is about 4 million per cubic millimeter. The main problem that may face neonates early after birth is the neonatal jaundice. The plasma bilirubin concentration will rise significantly. It could be even more than the normal value of 1 milligram. It can rise to 5 milligram per deciliter during the first 3 days of life. Then they will gradually fall back to the normal level. And the increase actually is due to the lack of or deficiency of function of the liver, the enzymes that are required to excrete bilirubin and conjugation of bilirubin are going to be non-functional or immature during the early weeks of the neonate, the early 1 week or 2 weeks of the neonate. But with time, the liver enzymes they are going to be produced, and the excretion of bilirubin is going to go back to normal. As you know, during pregnancy, the excretion of bilirubin is done through the mother's circulation, through the kidney of the mother and the liver of the mother. However, after birth, the excretion or the elimination of bilirubin should be done by the baby's liver and the liver is not going to be fully mature. The enzymes of the liver are not going to be fully mature. So that's what causes the neonatal jaundice, and it's called physiological hyperbilirubinemia. Regarding the neonatal digestive function, the ability of a neonate to digest or absorb food is just the same as older children, but there are three main exceptions. The first one is deficiency of the pancreatic amylase, which means the neonate will use starch less efficiently than older children. The second exception is absorption of fats. Absorption of fat in the neonate from in the gastrointestinal tract is less than that in older children. The third exception is liver function. It is imperfect during the first week of life, and that's why the glucose concentration in the blood is unstable and low in the first weeks. One of the main complications in premature baby that suffer from respiratory distress is the danger of blindness, which is caused by excess oxygen therapy. If too much oxygen was used, then the growth of new blood vessels in the retina will stop. However, after oxygen therapy is stopped, the new blood vessels will burst all through the vitreous humor. They will grow very fast and they will block light from the pupil to the retina and then might be replaced by fibrous tissue. So danger of blindness will be very high in these premature babies.